Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show. Hello, and welcome to Season 5 of Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. Anthony Kontos with us today. Today, we are going to be discussing everything from Dr. Kontos's career path to concussion risk factors, profiles and subtypes, and active treatments. So without further ado, let's meet Dr. Anthony Kontos. Dr. Kontos is a research director for the UPMC Sports Medicine Concussion Program and professor in the Department of Orthopaedic Surgery and Sport Medicine and Rehabilitation at the University of Pittsburgh. He has specialized in concussion research for 18 years with 220 plus peer-reviewed publications and over 390 professional presentations. His research is funded by the Centers for Disease Control and Prevention, Department of Defense, National Institute of Health, and National Football League, and focuses on active precision treatments and clinical trials, risk factors, neurocognitive, neuromotor effects, psychological issues, and concussion in the military, pediatric, and sport populations. Dr. Kontos is a fellow and past president of the Society for Sport, Exercise and Performance Psychology of the American Psychological Association and a fellow of the National Academy of Kinesiology, Association for Applied Sports Psychology, and Eastern Psychological Association. He co-authored with Dr. Mickey Collins, Concussion, a Clinical Profile-Based Approach to Assessment and Treatment, and we are so happy to have him on. Without further ado, let's meet Dr. Kontos. Welcome to Concussion Corner, Dr. Kontos.
Hey, Jessica, thanks for having me. It's a pleasure to be here.
It's a pleasure. You know, I've been a huge fan of your work that you've been pushing out for the last many, many years, and we're so happy to have you on so we can disseminate this information all over the world. So thank you so much.
Yeah, thanks again. You know, our clinic's been around for 22 years now and almost 23, and I've been a part of it for the last 13. Myself and Dr. Mickey Collins, you know, it's great to work here. We're excited every day to come to work and to see our research, you know, come into practice with what we do with our patients. So it's a great field to be in and a great time to be in it.
Excellent. Yeah, you know, we went to the first NYU concussion conference in 2011. We were the first 6 in New York City to go through residency as physical therapists in orthopedics, and we graduated in 2010, or we started in 2010, finished in 2011. And that was actually the first conference I attended that wasn't physical therapy solely related. Fast forward to 2 years later, I was in a car accident, and I still live with PPCS to this day. So it's really been full circle to be able to give back to the community, both with the podcast and with our academy, but your work and, you know, Dr. Collins' work at all has been so pinnacle, and really anything coming out of UPMC with Ann and Sue and the whole crew. So I'm really stoked to have you on today.
Yeah, thanks. And, you know, you bring up so many interesting things in that statement. Really, one of the keys is the role of physical therapy, right? So you mentioned Ann, Muka and Sue Whitney and Pat Sparto and others in our program too, that really have brought to the fore, you know, the role of the physical therapist, particularly those who are neuro PT trained for like the vestibular system, for example, and our exertion pieces. Those are just critical components in our assessment as well as our treatment model. You know, and I can't even think, you know, 13, 14 years ago, before the vestibular ocular motor screening, before clinical profiles, and all of these discussion points we're going to talk on today, it was just such a different field, and the role of the physical therapist was just coming to the forefront, and now it's so advanced, and we're so excited to be working with those folks.
Yeah, it's unreal. 2012, we just started talking about the cervical spine, in international consensus statements and how those are kind of connected, between, central nervous and peripheral nervous systems. And 2017 being the first year that we called the concussive injury rehabilitative through international consensus statement. But we know as physios, we've been treating, TBI really through the trenches as rehabilitation aids. Our profession actually just turned 100 years in 2021. So it's really been full circle, really, as a physical therapist, as one of our national spokeswomen for APTA, and also as a brain injury survivor. So it's really excited to have folks lean in today with us. If you're driving or on the treadmill, please don't lean too far. But I hope people are dialed into you today. So let's kick it off with, it's your first time on the podcast. We're so stoked to have you on. And I'd love to just have people get to know who you are that may not have met or heard of you before, and kind of how you got into, work as a really true research psychologist in the area of concussion. We have a lot of early TBI researchers coming on this year in 2023 for season 5. And I'd love for people to be able to kind of follow in your trajectory and steps to kind of keep shining bright on this concussion space.
Yeah, happy to do that. And I got to tell you, you never know where your path is going to take you. But if you follow kind of what you're interested in, and sometimes, it's about timing. And that really plays a key role in my path, as it probably does, many of your listeners' paths. And I think, to think of timing, I was back at Michigan State. So was Dr. Mickey Collins, and we didn't know each other. We happened to meet at a softball game. It was a really strange just coincidence. And, had a discussion about this concussion test that he was doing with the football team. And it kind of grew from there. And next thing I knew, a few years down the road, I was at the University of New Orleans after graduating with a PhD in kinesiology with a focus on sports psychology and also counseling psychology. So I kind of did a double major and focus. I was really, working more in sports psychology, but with an angle towards the psychology of injury, and had taught courses in that. And really, we started a concussion program at the University of New Orleans. We started looking at that from a research perspective, had Dr. Collins down to talk, attended a few concussion conferences. I don't want to date myself, but this is back in the early 2000s. And man, the field then, it was all about, grades of concussion and being, knocked out, losing consciousness and things like that. It was just so different than what it is now. And there was the development of neurocognitive testing. And then, that really exploded and made the field much more kind of a standard approach to the injury and looking beyond just symptoms. And I just happened to be at the right place at the right time when tools like that were being developed. And I got to be involved in that. And it really, my interest grew as I went to Cal State in Humboldt, and then was recruited to come to the University of Pittsburgh way back, it seems like forever ago, in 2010, and to start a research program here to really focus on clinical research. And that is my 100% effort here. And, I'm excited coming to work every day, because what we do in the lab and what we do in our clinical research literally comes to fruition every day as we interact with, assess, and treat our patients. And that's really the big draw for me now is seeing that in action, our research transitioning or translating into action and helping people and helping them get better, faster, and safer.
Yeah, and, I agree with, you kind of have to kind of go with where the universe takes you. And I was actually a clinic director for a prosthetics program for civilians. And that was a really underserved population in the area that I was working. And I just happened to get hit by a car. And I happened to get concussed. And I was like going through this 10 to 14 hours of rehab a week for 14 months. And I was like, I was ready to be like a door-to-door salesman, like selling vacuums in the 1960s. Literally, I was like going to speak to clinicians in order to kind of let them know about this active rehab approach and how to treat and evaluate and speak with patients and things like that. And then fast forward, here we are on the podcast. And that's kind of our origin stories, is we were having these conversations, as you know, over at a softball game or over an adult beverage at a bar or something like that at a conference. And these wonderful ideas happen. So it's hey, how can we disseminate this information? concussion. And I hope people kind of hear your excitement to come to work every day, because at the end of the day, concussion is an injury. And this is a quote from me as a patient. It's a loss of your I am. It challenges your function and everything and all of your capacity. I am funny, I am mother, I am wife, I am husband, teacher, thoracic surgeon, whoever you are. And it challenges all of those capacities. And what a better space to kind of interact with a psychologist like yourself and a physical therapist like myself to say, hey, how can we restore function for folks that are suffering from this injury? So with that being said, I would love to kind of hear about some of the concussion profiles and subtypes that have originated out of UPMC and the work that you've done with your team, and kind of how that has taken an active approach. Historically in medicine, historically with the injury of concussion and MTBI, we've alluded that folks are either malingering or looking for secondary gain because we weren't doing these comprehensive targeted physical examinations to identify these profiles and subtypes that you've identified. So I'd love to kind of hear a little bit of the origins of kind of how these profiles and subtypes have come up, and then we'll hop right into the CP screen.
Yeah, absolutely. And, we first published on this in 2014, but as you know, there's always like a 2-year lag, right? So really the moment I got to Pittsburgh in 2010, we were all starting to, really acknowledge and investigate, what are the different types of this injury? It wasn't just you're concussed or you're not, but rather you have a concussion. We've established that. Now let's figure out what type and what can we do to get you, returned to whatever it is you're doing. Because we don't just see athletes. So it's not always, sport. It might be return to, working for FedEx or UPS or something, and maybe going back to the classroom to teach, who knows? But really the focus early on was, vestibular came to the forefront. And it was real clear that there was something unique with dizziness, these vertigo-like symptoms, imbalance, that they were kind of clustering together. We certainly already knew a bit about cognitive, and we had, as well as many other groups, published on migraine, right? So, post-traumatic migraine. So for your listeners, that's headache, nausea, and then sensitivity to light, which it sounds, I think we were talking earlier, something that you were familiar with as a patient, and also sensitivity to noise. So you might have a constellation like that, that's like a headache with a very specific subtype, right? And we started looking at those things, and then vision. Vision came on, and we refer to it like as ocular or ocular motor. So it's really the coordination of the eyes and sensory input, and really the importance of, that system. And so then later, and this is the one lately that's really been like front and center, is anxiety, mood, right? And so, those first 4 that I mentioned, so cognitive, migraine, ocular, and vestibular, we have really good approaches to evaluating those, to treating those. I look at anxiety, mood as the real challenge, because a lot of that, much like migraine and some of the other ones, is what you bring to the table. So that's critical in driving these pathways. Our research has shown, if you have a migraine history, you're much more likely, about 60% of those patients will go down a post-traumatic migraine pathway. And we see the same thing, and probably even more so with anxiety. And in fact, anxiety kind of bleeds into other profiles and affects them. I was just doing an analysis that one of my staff members and our fellows submitted to SNS, the Sport Neuropsych group, and it's focused on the relationship of anxiety as predicting almost all of the problems post-concussive with sleep. So in other words, the people that have sleep problems post-injury following a concussion are the people that are either anxious before they get injured, or they have a CP screen anxiety score that's pretty high. So we start to see these interrelationships among the profiles, which is really neat.
And we are going to you have no choice. You're going to come back on the podcast, and we're going to talk about anxiety and mood the whole time, because I think that's so important. And I'd really love to go into a little bit more depth in that. But we see on average, at least with my practice in the city, in New York City here, is that I've paused for the last 1.5 years to build the academy. But what I was finding is on average, 6 to 8 patients were seeing me before they arrived to me, because they're looking for a specialist, and, or they didn't know they need to look for a specialist in concussion, because the assumption is that folks, would know how to manage it and treat and manage on average. And I know that you guys have a traveling program at UPMC, and I do want to talk on the CP screen because I know we're short on time. But on average, I know you guys have your traveling on. Do you guys keep track of that at UPMC? Because I know you see up to like 20,000 patients per year for concussion. Is that right?
Yeah, it's really so that's visits. So it's 8,000 unique patients, right? So each patient probably has somewhere between like 2 and 4 visits, depending on their injury and what's going on. And you mentioned traveling. We have a large number of patients that come from out of state, and those patients really it's like a concussion day for them. They get a full assessment from the morning to the afternoon, and we do, a case adjudication, conceptualization with the team, and really get their therapy in line before they leave, so that when they go back to New York or to Boston or to wherever, they're able to kind of go there with a plan and initiate that locally with the therapist that they have access to wherever they are.
Yeah, that's so important. And for me in my practice as a physical therapist, I see a lot of anxiety and mood from patients because they've been mismanaged in the line before they arrive to me. So I think that's going to be a lovely conversation to have in the future of, how are we looking at anxiety, just like pain? We know that pain can be, extrapolated into 20 different types of pain. And then same thing with headache and migraine. So I would love to have that conversation with you in the future on anxiety and mood. And speaking of anxiety and mood being part of the clinical profile screening tool that you've developed, I would love to kind of hear the origins of this concussion clinical profile screening tool. I know this is preliminary evidence to inform a multidisciplinary approach. I think it's important that we highlight the multidisciplinary approach to concussion, on this podcast, and then just kind of origin story, and then what you found, and the kind of where you see the future of this tool going.
Yeah, sure. Well, obviously we had this model, and when you have a model, you have to think of how do we assess what's in the model. And we had some tools that were available, neurocognitive testing, as I mentioned. There was a symptom scales, but we really struggled because they're kind of, I don't want to say vague, but they're more about like, do you have an injury, not what type of injury do you have? So a good example is, the standard concussion symptom inventories ask you, do you have a headache and how severe is it? But it's not what type of headache, right? It's not when does it occur? Is it in the morning? Is it when you do physical activity? Is it when you do screen activity like we're doing right now on this podcast, or is it at some other time? And that's the critical piece that was missing, right? Was the specificity of the symptoms for each profile. And so we went to the drawing board a bit, and we got 10 experts from around the country that we solicited input, and we developed items. And those items were really designed to get at what were sort of like subtypes of the injury or profiles. And again, we had a model, but we always are evolving that model. And we had items that we thought were going to be great, and they ended up statistically, they were like a mess, right? And a lot of times that's because they go across different profiles. And I think that is an important acknowledgement, is that although the profiles each profile is very important, and it's often looked at sort of like independently, there is overlap in the profiles, and profiles often co-occur. And we've published on this as well, right? And we know that like migraine, goes with anxiety. Vestibular can go with anxiety, but vestibular can also go with migraine, and ocular can also go with migraine. And so you start to get these connections, right? And the CP screen, the clinical profile screening tool, really allows us to get an initial assessment from the patient, like what symptoms are they experiencing right now, and how do those then start to aggregate and to form these different profiles. And we also look, and I didn't mention this earlier, we also look at what we call modifiers. They're kind of associated factors, and that's the neck or cervical involvement. That's pain in the neck, or is it, motion difficulty with moving the neck? And then we look at sleep, right? And we don't think of those as profiles per se, but they can certainly interact with and affect concussion and recovery and things like that, and definitely need treatment when they exist.
Yeah, and you said so many salient things there. So, I express both as a persistent post-concussive symptom human that thrives with their symptoms on a daily basis, neurofatigue, and so on. I said that during my recovery from the acute concussion in 2013, 2014, I said patients do not have the subjective language to express the what and how they feel. And I'll say that twice for our listeners. Patients do not have the subjective language to express the what and how they feel, which is why it's so important, because we're asking our patients 27 times a day, how do you feel? What's your pain? What's your VAS? They have no idea. They do not have an idea on how to express what a migraine feels like, or vestibular systems, or differentiating an ocular motor issue, or oscillopsia, no less, in the middle of a grocery store or something like that. So this is so very important for our listeners who should be healthcare listeners, healthcare professionals listening into the podcast, to be able to use this screen in order to kind of dial in and dial down. What I find as both an educator and as a provider, as a physical therapist, is that both patients have overwhelm with concussion, which is not a secret. But I think the other side of it is that providers also feel overwhelmed. It's like, where do I start? How do I even triage this injury if someone's coming in lit up, and if there's any other things going on in life, because it's such a heterogeneous injury. People are heterogeneous. Everyone's stressed out in pandemic and endemic times. We just don't have enough time, and all the resources are limited these days. And attention is our most valuable resource that everything is vying for, from the pings on our iPhones to our Apple Watches and so on. So I can't stress enough, because I know this is a Concussion Corner short with us today. It's not our usual 2-interview process, but I really want folks to really dial in. And how can folks get access to the concussion, the CP screen? How can they get a hold of it? And how do you envision this being used in the future, or even present day?
Yeah, so it is, free to use. It's out there. If you just do a search, frankly, your usual Google search, you'll come up with it. The article had an appendix with it in there, and it's available there. I often get emails about how to score it and how to look at it, and that's something that's evolving. Right now, we're trying to develop, and we are in the process, manuscript that's in review, looking at clinical cutoffs, right? So are you sort of positive or negative for a profile? And one of the things you mentioned early in that was, in your comments, was kind of this constellation of like, there's all these different things happening. How do I subjectively interpret it as a patient or as a clinician? And I think that's what, the CP screen is really good at. But I think it's also different based on when you give it, right? So if you give the CP screen like on day 2, there's a lot going on with patients. They tend to report a lot more symptoms, right? But as you go further in time, you start to really parse out more and more, what are the problematic areas that really require treatments, that require active, targeted treatments that aren't necessarily going to, as a patient, get better on their own. They're going to need that expose, recover of vision therapy or vestibular therapy or exertion-based therapy or behavioral management. And I think the CP screen really plays a critical role in helping to identify the initial impairments that can help guide decision-making by clinicians and the referral process as well.
Yeah, and I think we know that early active treatment here is a no-brainer, and we need to be able to disseminate that like 360 all around the world. And we're no longer, I should say, we should not be in the days of, but we know that this is still happening out there for providers that are not educated on how the active roles and profiles of concussion and how to treat this rehabilitatively. So with that being said, I want to make sure that folks lean into that. We're looking for an active approach. We're looking for an early referral process. We're making sure that we're disseminating information that here's what I can do as a physio, as a psychologist, as a nurse, as an OT, a speech pathologist, and so on and so forth. And here's how we can treat together. And it's so important to be able to objectively measure these profiles in a concussion patient, whether it be acute, subacute, or persistent. And this tool is here for you. And I really can't endorse it enough. And I'm so stoked to have you on, Dr. Kontos. If folks want to find you on social media, we'll have all the links in the show notes to the tool, to your bio, to everything like that. But how can folks find you on social media if they want to reach out?
Yeah, I'm on Twitter professionally at Dr. Kontos, and Dr._Kontos, DR. And I'm also on the web as well, and people can email me. They can look that up. I'm happy to talk to folks. And honestly, I think that was a real problem with our field a few years ago, 10 years ago, is there was a lot of siloing going on, not a lot of talking. And more, I think we're seeing sort of people coalescing with opinions. A good example, active treatment, the importance of that, and doing it early. We've published that if you get in sooner, you get better faster, and you get better in a way that's more targeted, efficient, and won't lead to things like anxiety and all those other problems that patients often experience.
Yeah, and I can't stress that enough, is that when folks are unable to function during their day and they're unable to identify that, that's going to definitely lead to anxiety. And it's incredibly important that we get folks screened early. And then again, you understand the difference between what a day 2 acute screening tool looks like, and then also a day 14, day 21, or even month 3. And this allows them to actively track that objectively. And again, I'm really excited to see where this goes. And thank you so much for coming on Concussion Corner.
Thanks, Jessica. It was a pleasure to be here.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.